So welcome to the section of mitral and tricuspid intervention. I am Shih-Hsien from Taipei Veteran Hospital, Taiwan, and with co-chair with Dr. Jung-Sun Kim from Surveillance Hospital, Korea. And we also have numerous panelists, Dr. Chiam, Dr. Kim, Kubo, Shunsuke, Simon Lam, Dr. Lam, and also Dr. Lin, Dr. Meemook, and Dr. Nuruddin, Dr. Park, Dr. Shirai, and also Dr. Wong. And we all know that tricuspid valvular therapy already reshaped the landscape of structural heart intervention. And also, while mitral valve TEER has already been the cornerstone to treat patients, especially functional now. And tricuspid valve intervention nowadays is an emergency therapy. So today we will have numerous sections to discuss, to share the updated knowledge on the mitral and also tricuspid intervention. And I would like to welcome our first speaker, Dr. Jung-Sun Kim. He will share the updates of the mitral TEER in secondary mitral regurgitation.
Thanks for kind introduction. It's my great pleasure to have the opportunity to give a presentation in this meeting. So I would like overview of the mitral TEER recent update. Here's my disclosure. Let me start with the recent guideline. As you can see here, there is some discrepancy between US and European guideline. As you can here is a TEER is a class 2A indication is in US guideline, especially in patients with co-op criteria. However, it's more broad indication for the European guideline as a class 2A, suggesting an increasing chance of responding to TEER, as well as class 2B indication for the more advanced heart failure and high-risk symptomatic patient. So here is one interesting study, Mitral trial, which was presented at the last ESC meeting, comparing TEER versus surgery in 210 patients with moderate, severe, or severe SMR. In this trial, TEER was non-inferior to surgery in terms of primary endpoint. However, 30 days event in terms of safety, TEER shows a superiority. Safety compared to the surgery. But instance of MR grade 1 at 1 year, surgery achieved more than TEER procedure. So let's move on to indication. I think this indication is already known, but need more answer, appropriate criteria for atrial functional and early intervention for the moderate MR. I think it's deal with the next speaker, bridging therapy for the advanced heart failure with the mitral regurgitation. Here's a landmark trial, co-op and mitral FR trial, but there is some opposite results. Based on this finding, we know the patient with the co-op criteria achieved more favorable outcome after TEER procedure in secondary mitral regurgitation. Especially so, we have some concept of the disproportionate MR, which is a more valuable, more beneficial population for the TEER procedure in secondary mitral regurgitation. Also, the recently published Reshape Heart Failure 2 trial was presented in last ESC meeting. I think it deal with more next speaker. But this trial shows the device treatment maintained the treatment better outcome compared to the maximum medical therapy in terms of MACE as well as quality of life. But I would like to point out two important message from this trial. First one is apply more comprehensive GDMT, including SCL2 inhibitor than previous trial. That means lower mortality in GDMT group, 14% versus 23% in previous trial. Second one is include less severe MR compared to the previous trial. That means it's possible to expand the indication for the TEER procedure to the moderate mitral regurgitation. So here is a indication. Previously, most important indication with the patient with the co-op population patient. However, we can include more patient group reshaped heart failure trial, less severe MR, but more remodeled LV volume in this population. Also, the other interesting study published in Moderate Functional MR with the expanded registry. They compared two population, moderate and severe, almost 300, 500 patients included. In this study, MTEER for moderate SMR provides clinical benefit comparable severe SMR, including MR severity, as you can see here, and LV remodeling, but great remodel and moderate functional MR and improved quality of life and function. So this outcome suggests an opportunity to treat the patient with a moderate SMR with MTEER procedure. So next part is advanced heart failure with MR, mitral regurgitation. So this is another definite indication, but we can expand the indication for this with the TEER procedure as a bridging therapy before transplant or BOD. So last part is outcome, need more answer, long-term durability, more data, atrial functional, and optimal degree of MR reduction and optimal treatment strategy of mixed MR pathology. So one of the important study is a long-term follow-up data. 5 years follow-up data of the co-op trial is device treatment is maintained the benefit compared to GGMT until 5 years in this study. And the other study is Euro SMR registry. It's also 5 years follow-up, and this study shows a long-term MR reduction is around 85% MR is maintained for 5 years, and functional improvement is maintained around 60%. But relatively lower survival rate at 5 years, 35%. So we need additional therapy in high-risk population of heart failure. One of the important findings is great reduction of MR and index procedure was associated with improved long-term survival. That means the intervention is to strive for the highest achievement MR reduction in index procedure in secondary mitral regurgitation. So last part is how about the outcome, the different phenotype of the secondary mitral regurgitation, atrial functional versus ventricular functional is quite comparable in Euro SMR registry, but Sinai registry shows ventricular functional MR worse outcome compared to the atrial functional MR. So in summary of my presentation, isolate severe SMR, TEER is recommended as a first-line treatment option. Moderate SMR, some clinical benefit of TEER has been observed in Reshape Heart Failure 2 trial and Mitral trial. And lastly, atrial functional MR, advanced heart failure with MR. Current evidence insufficient, but further study are required to establish clinical indication. Thank you for attention.
Thank you, Dr. Kim, for the nice update of the mitral TEER in secondary MR. And our next speaker will be Dr. Wojciech. He will bring us to deep dive into the Reshape Heart Failure 2 trial.
Thank you very much. Let me discuss the Reshape HF trial, which we participated in Europe. So it was a European investigator-initiated study. So why do we need additional information? Because first of all, the functional MR it's very frequent, and also this trial gives the answer on the moderate functional MR, which is roughly 40% of patients with functional MR and heart failure have less than severe MR. So also for the indications in the guidelines, we need to have consistent information, and previous trials were inconsistent in their outcome. So we were based mainly on the results of the co-op study for guidelines related to the treatment of valvular heart disease. So this population of the patient is different. So in comparison to co-op and MitraFR, the age, renal function levels of NT-proBNP and the ejection fraction is similar, but let me draw your attention to the EOA, which was significantly less. But at the same time, when you compare the ventricles, for MitraFR, the end diastolic volume was 250, for co-op was 194, and for Reshape HF was 210. So those patients had less remodeled ventricles than the MitraFR patients. So the design of the study, it was a randomized study in which patients were either treated by state-of-the-art GDMT or underwent clipping with the MitraClip within 14 days after randomization, and the patients were qualified by the heart team, including surgeon, and also the echoes were reviewed by the core lab, which gave green light for randomization. So those patients were symptomatic in class 2 to 4, ejection fraction of 20 to 50. Those patients had either heart failure hospitalization or increased natriuretic peptide, and all of them had a clinically significant mitral regurgitation. But definitely less patients than 2 other studies were in the category of severe functional MR. So the endpoints. So there were 3 primary endpoints, and analysis was done using the Hochberg procedure, which allowed, without losing the statistical power, analysis of 3 primary endpoints. The first was recurrent events of cardiovascular, of heart failure hospitalization or death, then recurrent events of heart failure hospitalization and KCCQ, as the secondary endpoints were 6-minute walk test and New York class, and also the grade of the MR after 12 months. When we look at the group of the patients and the characteristics, those patients were both non-ischemic and ischemic, and this was a stratification factor for randomization. They had preserved renal function, and they were a little bit more intensively treated, and the treatment was more modern than other 2 studies, but again, Reshape HF was enrolling over 6 years, so it's not that contemporary study as we may think. It took 6 years to enroll those patients. So still use of SGLT2, it's around 10%, which is not representative of the current practice. When you look at the echoes, those patients had decreased ejection fraction, and the ventricles, as I said, were around 200 milliliters. And less patients were in severe category, and majority of them in moderate to severe. So the primary endpoint of composite hospitalization for heart failure or death was reduced by almost 40%. And also the hospitalization for heart failure was reduced by the same factor. There was an improvement of quality of life, which was also significant. And there is no heterogeneity across different subgroups. But if you look at the lowest one, the patients who had hospitalization within 1 year before the randomization had better improvement. And I will continue on this in a moment. The secondary endpoints were also improved. There was a significant reduction of the MR, and there was no difference in mortality. That's different from the co-op study. Also, this procedure was safe, and then again we were using the older generation of clip, with majority of patients under general anesthesia having 2 or 3 clips. Now this procedure looks much different. In majority of patients we use 1 or 2 clips, so it also provides some data on safety of this procedure. Then the second analysis, and it was pre-specified analysis published in JAG, showed that there is a particular benefit of this treatment if patients were hospitalized within 1 year before the randomization, and not only hospitalizations, first hospitalization after the clipping is reduced, but also recurrent rehospitalization. So we know that those hospitalizations may come at the cost of or poor prognosis, because each heart failure hospitalization is related to increased mortality. Also, cardiovascular hospitalizations were reduced. So putting this all together into meta-analysis confirms an improvement in heart failure outcomes, especially heart failure hospitalization. So again, having this concept of proportional and disproportionate MR, those patients were still on the left side, what we consider a disproportionate because of less remodeling of the ventricles, despite the fact that they had less regurgitation in relation to the ventricle. It provided them enough reserve to improve after the clipping. So in conclusion, the primary endpoint of the study and secondary endpoints were positive. There was no difference in mortality, but improvement in quality of life and heart failure hospitalization. And this study was done in Europe, and majority of patients were included in Greece and in Poland. And further analysis will be published soon. Thank you very much.
Thank you for your nice lecture, Dr. Wojciech. So let's move on to next speaker. Next speaker is Shih-Hsien from Taiwan. He will talk optimized TEER through comprehensive hemodynamic assessment. Dr. Sung, please.
Thank you for having me in this section to present optimizing TEER through comprehensive hemodynamic assessment. My disclosure. We all know the hemodynamic impact with mitral TEER procedure. This is one of the earliest publications describing the acute hemodynamic effect. Basically, it involves in increasing cardiac output in treating patients with majority DMR patient. Basically, it involves in increasing cardiac output, decreasing left ventricular and diastolic pressure. The wedge pressure means pulmonary artery pressure would remain the same. In addition, patient will have increase in systolic blood pressure and also decrease in systemic vascular resistance. What are difference? There are also subtle difference between patients with DMR or functional MR. However, universally, both etiology of patient would have increase in cardiac output, especially for stroke volume, and decrease in left atrium pressure and also V-wave pressure, which would be predominantly observed in patients with DMR. They also would have decrease in systemic vascular resistance. The pulmonary wedge pressure will remain the same in acute. In acutely immediate after procedure. However, patients with DMR would have decrease in left ventricular and diastolic pressure, but patients with functional MR would have increase in pulmonary artery pressure. So what underlying mechanism make this a difference between two etiology? This is a nice paper simultaneous to assess left ventricular pressure volume during mitral TEER procedure. So the most notable change would be the increase in left ventricular and systolic pressure from the black circle to the baseline to the red circle after the procedure. So the end systolic pulmonary vascular relationship, pressure volume relationship, which is the slope, actually correlate with the intrinsic myocardial contractility, remain the same immediate after mitral TEER, because increase in afterload, and there would be increase left ventricular and systolic volume, and therefore we would observe the left ventricular decrease in left ventricular ejection fraction. And regarding the wedge pressure, which can be observed to significantly decrease after procedure, however, there will be discrepancy in left ventricular and diastolic pressure, which is be predominantly observed in patients with DMR in black, but not in patients with functional MR. Also, there would be increase in end-systolic pressure, which would be indicating increase in wall stress at end systolic. However, there will be a constant increase in cardiac output regardless of the afterload. The most notable change would be, a benefit would be the decrease in preload, which like the end systolic, the wall stress at end systole correlate with the change with wedge pressure. So we mentioned about the decrease in left ventricular ejection fraction, which is not uncommon after mitral TEER procedure. This is a very nice paper from Ocean Mitral Registry of more than 2,000 patients. 1/3 of them would have a decrease in LV ejection fraction of over 12.9% after discharge. However, the worsening ejection fraction did not correlate with the long-term outcome. So what makes difference in the long term? This is also this is data from Germany with a follow-up of almost 280 days with majority of patients with functional MR. It it assesses the ED-PVR and also ESPVR by non-invasive by echocardiography. It nicely shown on the right-hand side when patient has baseline every ejection fraction less than 40%, there would be the PV loop would be the same. On the left-hand side, if the patient have the every ejection fraction baseline over 40%, there will be a leftward shift of the PV loop, and also the ESPVR, the slope of ESPVR would a bit steep, which indicates that patient with baseline preserved ejection fraction would have significant reverse remodeling as well as the intrinsic myocardial contractility, which may echo the data from the reshape or from the expansion for registry. When we treating patient with moderate MR with smaller left ventricle, the patient might easily to get reverse remodeling in left ventricle. So what are the relationship between these hemodynamic parameter and also the outcome? This is the paper published by Shunsuke. He defined the responder by according to the increase in stroke volume of over 9%. So you may appreciate that patient who have significant increase in systolic forward stroke volume immediately after procedure would have better long-term survival and also better reverse remodeling in left ventricular and diastolic volume as well as left ventricular and systolic volume. However, whether the patient are responder or not, they can all get symptomatic benefit from mitral TEER procedure. The other parameter index, including the V-wave, the wedge pressure, which is same as LA pressure, and also the mean pulmonary artery pressure, also can predict the long-term outcome in terms of mortality, MR surgery, and also heart failure hospitalization. So they are also proposed a novel hemodynamic index, the so-called mitral pulse pressure fraction, which is the difference between V-wave and also mean LA pressure divided by the systolic arterial pressure. We can show the more change in the mitral pulse pressure fraction, the patient would have more would have better improvement in NYHA functional class and also the KCCQ. So how can we apply this hemodynamic index during our daily practice? This is the data published by Post-Raj. He defined it, he categorized the patient according to the residual MR and also the LA pressure. When patients have residual MR equal less than 1 plus and also LA pressure equal less than 15 millimeter mercury, those patients are categorized as optimal hemodynamic profile. When patients have residual MR over more than 1 plus, which means more or equal than 2 plus, and also LA pressure of more than 15 millimeter mercury, which are categorized as poor hemodynamic profile. When patients have one of either index, which would be categorized mixed, you may appreciate when patients have more unfavorable hemodynamic index, the patient would have worse long-term survival. By using the Cox multivariate analysis showing that the TEER and also hemodynamic profile are the only independent predictor, but the mitral valve pressure gradient did not predict the outcome. When we focus on the patient who have residual 1 plus equal or less than 1 plus MR, you still can appreciate a patient with high LA pressure over 20 would have significant lower long-term survival. The data also from another group from Mayo Clinic also showing that LA pressure is very important. However, the predictor for LA pressure involve the baseline LA pressure and also the mean gradient. So therefore, the mean gradient didn't make sense for the long-term. And in conclusion, also mitral TEER index hemodynamic unloading, induced hemodynamic unloading in patients with severe MR, cardiac reverse remodeling is not consistently observed, especially in patients who have too dilated left ventricle. Universally, we may observe an increase in cardiac output and a decrease in LA or V-wave pressure when severe MR is abolished. Suboptimal improvement in LA pressure might offset the efficacy of mitral TEER while pursuing less MR with consequences of greater post-TEER mitral valve pressure gradient. So we may redefine the procedural success with residual MR equal less than 1 plus and also post-TEER gradient less than 5 millimeter. When we have complete, we can check the LA pressure. Thank you for listening. Thank you.
Thank you for a wonderful lecture, Dr. Song. I think it's a very comprehensive review of the hemodynamic change after acute hemodynamic change after TEER procedure. So let's move on to the next speaker, Takao Morikawa from Japan. He will talk, is MitraClip G4 good for Asian patient? Insight from expanded G4 study. Dr. Morikawa, please.
Thank you, Dr. Kim. So I'm happy to be back in TCTAP 2025. So let me start my presentation. And this is my disclosure. So this is my background. And as you guys realize, the Asian patient have small body. And this issue illustrated the patient characteristics, management, and outcome of the mitral regurgitation and from the Asian patient and European country. So I'd like to focus on the patient characteristics. And as you can see, this left side red bar is Asian patient, and this right side blue bar is European patient. So Asian patient has a smaller body size and also have a smaller left ventricle size. On the other hand, Asian patient has a bigger left atrium size. So this means proportion of the Asian patient's mitral valve is a bit different from the European patient. So here we have a question. Is TEER suitable even in Asian patients? Actually, we already have some answer from Japan. So here we have a 3 registry data. So these 3 data supported to the favorable TEER outcome with a MitraClip device. So today, I'd like to talk about Expand G4 registry result in which I was involved. So what is the Expand G4 study? Expand G4 is a prospective, multicenter, single-arm study that enrolled over 1,000 patients treated with MitraClip G4 system from US, Europe, Canada, and Japan. And actually, Japan is the only country from an Asian country. So then we did the analysis of the Japanese cohort. In this study, we assessed 95 patients from 7 hospitals. And this is a key outcome measurement as seen in below. The biggest feature of this study is every single echo category is assessed by echo core laboratory, including MR severity. This is a baseline patient characteristics. This left side is a Japanese patient. This right side is the entire cohort. As you can see, Japanese patient has a small body size and also have a high surgical risk. Let's move on to the echo parameter. In the echo parameter, a Japanese patient have a small mitral valve area and small left ventricle size, but looks like almost similar left atrial size. This is consistent. This result is consistent with previous data. So then we have a question: how we treat this small mitral valve patient? So this is a procedure result. Procedure result looks pretty cool, and implant rate is 100%. It means perfect. And acute procedure success rate is 98%. It looks almost perfect. And the number of the clip is 1.1. This means most of the Japanese patient was fixed with only 1 clip. And this is the prevalence of the device size. The left side is entire cohort. The right side is the Japanese cohort. In entire cohort, the patient was mostly fixed with XT-double device, and also 22% of the patient was fixed with multiple clip implantation. On the other hand, 95% of the Japanese patient was fixed with only single clip, and the Japanese patient's working force is NTW. And 25% of the patient was treated with narrow clip. This means Japanese patient was fixed with small single clip. So how this clip behave? This is the outcome. This outcome looks really cool. And in baseline, now over 70% of the patients suffered with more than moderate severe mitral regurgitation, but right after the procedure, over 20% of the patient can achieve the MR less than 1 plus. And this effect is consistent with for 1 year. And at 1 year observation, MR less than 1 plus was achieved in 98%. This looks also great. And this is the MR reduction and through by MR etiology. Both primary MR, secondary MR, the results were consistent with etiology. And the Japanese patient has, as I told, a Japanese patient have a small mitral valve area. So how is the change of the mitral valve gradient? So this is the baseline mitral valve gradient, and this is right after procedure. Only a minimal change was observed, and it is maintained. So this means we can treat the patient with safe. And this is procedure outcome. Actually, this is a single arm, but the result looks good and consistent with previous studies. The all-cause mortalities is about 10%, and heart failure hospitalization is about 20%. And in summary, Japanese patients have smaller mitral valve, small LV, and high surgical risk. But we tend to choose smaller size of device. Despite them, we achieved great procedure success rate, durable MR reduction without mitral stenosis, lower in-ear mortality and heart failure hospitalization. MTR using MitraClip is good in small Asian heart with utilizing 4 sizes of clips. Thank you so much.
Thank you for Dr. Morikawa. So it's very valuable presentation to share the experience of the Asian population with the MTR. So last speaker in mitral session, Do-Yoon, he's now in US, not Korea. So actually he will talk AM's data of mitral TEER. Dr. Gang, please.
Yes, thank you for your kind introduction. I will introduce the brief data of the Asa Medical Center of the mitral TEER procedure. I really am with the Japanese guys, Kubo and Morikawa, about the big nationwide registry and the bigger size of the patient population. And still, in Korea, there are small numbers are performing the TEER procedure, 15 centers of 300 cases, and still not covered by national health insurance because of the recent some crisis in Korea is some delayed. So you can there can be some bias in the selection of the TEER patient in Korea because of the high price. The patient in the very advanced stage patient select the TEER procedure by some referral. And in Asa Medical Center, we did the 119 cases, and 56% was a degenerative, and otherwise was a functional. And interestingly, the 15% of the patient was atrial functional MR. And this is the clinical characteristics. The table is a bit busy, but you can see the ventricular functional MR patient is younger and has a more diabetes and has a higher previous cardiac surgery history and previous myocardial infarction. And the STS score for MV replacement was about 11% in overall patient. And this is the echocardiographic characteristics that shows that ventricular functional MR patient is different from other etiologic patient. Has the lower EF and bigger LV diameter and volume, and higher E over E prime, and larger array size with a huge array volume index in atrial functional MR patient. And you can see that this is really huge array in atrial functional MR patients. And the MV area was about 5.6 square centimeter with the EROA was mean 0.6 square centimeter. And 3 or 4-point TR was accompanied in about 1/3 of patient and very high, about 70% in atrial functional MR patient. And this is a procedural characteristics. The mean number of the clips was 1.7. And as you can see, the first clip, we prefer the XTW. And second clip, for the ventricular functional MR, more various. And atrial functional MR, 2 XTW clips was mostly used. And immediate post-TEER echocardiographic result shows that the LV ejection fraction is still low, and MR more than moderate was about 16.8% after procedure. And in atrial functional MR patient, still a higher proportion of the patient had a residual MR. That would be it is showing the distinguished etiology and the clinical characteristics of the atrial functional MR patient. And mean mitral valve pressure gradient was of average 5, and the mitral valve area was about 2.3 in pressure half time and 2.5 in 2D image after procedure. As you can see in this table, the LV ejection fraction was immediately decreased about 60% in population, overall population. And the primary and atrial FMR, it was similar. And the volume was decreased in 17 milliliter in diastolic volume, and systolic volume was not different from the baseline. And LA volume was immediately decreased about 11 milliliter index, and TR Vmax was not different after the procedure. And follow-up echocardiographic after median 10 months, the LV decrease in the LV ejection fraction was sustained, and you can see that the LV volume and LA volume has decreased dramatically, and especially in atrial functional MR patient, LA volume index was decreased in average 93 milliliter per square meter. It was the dramatic decrease. However, the degree of the MR more than 2 plus has increased at 10 months, a little bit different from the Japanese data. And there can be some bias in the patient selection, or including the early learning period of our whole center, whole patient, the registry. And the mean mitral valve pressure gradient was not different, and TR Vmax was also not different after the procedure. The 1-year clinical outcome, all-cause death was 4.2%, and CV death was 1.7%, and one patient in ventricular FMR patient was the immediate post-MI MR patient that passed away just after 4 days. And rehospitalization was 10% during the 1 year, and was higher in atrial functional MR patient. And in conclusion, patient underwent mitral TEER at distinct clinical and anatomic characteristics by the etiology of the MR. And mitral TEER showed favorable echocardiographic and clinical benefit for high-risk MR patient, and larger size nationwide prospective registry for MTEER in Korea is needed. Thank you for your attention.
Thank you for your wonderful lecture, Dr. Kang. I think it's very valuable data in Korea for the MTEER procedure. So we have some time for discussion until around 15 minutes. Is there any question from the audience or panelists?
I'm Song-ji Park from Samsung Medical Center. So I have a question about Wojakowski. So considering the result of the reshape heart failure 2 trial is a no benefit of the cardiovascular mortality outcome, and the second is the value, emphasize the value of the role of GDMT, including the SGLT2 inhibitor, compared to the TEER in that secondary mitral regurgitation in HFrEF patient. So do you think we reconsider the current treatment current treatment strategy, expanding of the TTR in secondary mitral regurgitation, including the moderate mitral regurgitation, especially in patients with LV, advanced LV remodeling? What do you think about that?
Well, I think first of all there is an improvement of the medical therapy that gives a lot of improvement in the outcome.
Yeah.
So I think that the qualification for the TEER should be for patients who remain symptomatic despite having the guideline-directed medical therapy, CRT if needed. So I think this is the first line of treatment, and this is improving the patient's outcome. I don't think that we have much data to support a treatment of patients with extremely remodeled ventricles. So I think for those patients who are younger and have better overall perspective, then there are some LVAD therapies, other ways to improve their quality of life. But I don't think that we should move to patients who have who are truly proportionate. So for such patients, I think that there is a LVAD, advanced therapies for heart failure. So that's the key point. But I think what we should do is we should consider patients who are truly symptomatic, despite having everything we can up-titrate with the medical therapy, and they have less than severe MR. It's probably better to treat them earlier, especially before they develop the right heart failure, than to wait until they have truly severe MR. That's I think the conclusion of this.
So one quick question. So in US, in European country, is it possible to treat with for some moderate MR? Because in Korea, I think that there is some problem for the coverage by insurance. So we usually wait for until severe status. So that's another some issue. I think there is some LV reserve. If there is some reserve, we treat MR, then we can get a more good prognosis. So what is your usual practice in European country?
Well, it's very diverse throughout Europe. Many countries, they have the reimbursement rules are more technical. At least in Poland, they are not truly saying what phenotype of patients you should treat. But I think, those patients were moderate to severe. It's probably combination of the factors that maybe new guidelines will help, because we'll have new guidelines in August, European cardiology and cardiac surgery guidelines. So maybe it will give some boost for. But I think what those patients are truly the patients in European registries. Different than in the US. In Europe, we're treating secondary MR, using the data from Everest, which was reversed from the US. So I think it's European experience to treat the secondary MR.
Yeah, I have a comment and question, but regarding the GDMT in patient in moderate MR, patient with ERO between 0.2, 0.3, I think the role of GDMT is the most important factor. In reshape HF2 trial, the use of RNA is around 11%, and the use of SGLT2 inhibitor around 10 or 9%. If they use the RNA or SGLT2 inhibitor up to more than 90%, I think the result of a study may be different thing. How do you think about the GDMT?
I agree. If we use the SGLT2 and RNA in majority of patients, I think a lot of them will become asymptomatic. So this will help us guide our therapy to only very severely symptomatic patients.
I have a question. I think over the years, most of us procedure success, anything less than 2 plus MR, we are fine. But I think as more of us find that you have to try and get minimal MR, even 1 plus. So would that be a consideration later, that this, because of the newer clips, the different sizes, you should aim for MR 1 or less to see that the results, long-term results will be better? Despite, I agree that GDMT is one thing that you have to optimize. So is it that we should change our procedure success for less than 2 MR to something more stringent?
Well, yes, I think we should do our best to achieve the fullest reduction we can have. Also, it's not always left atrial pressure, for example, for us. Sometimes we see the color jet, it's not really pretty after the clipping, but we see the improvement in pulmonary flow reversal and we see the drop in LAP. So I think it's probably clinical practice shows that it's, you know, the single parameter, it's not enough, but we should try to do as much as we can to reduce the MR.
Yeah. So I think MR reduction is very important, but we should consider the MDPG and LA pressure is also important. So any other questions? Yeah, go ahead.
So I have a question for Dr. Song, because I'm always confused about the LA pressure, because in our experience, sometimes MR reduces a lot, but it still has, the LA pressure doesn't change. So can you predict the change with the improvement of the LA pressure? Because I think the LA pressure was influenced by a lot of different conditions like LA compliance, even the right heart, or the functional, or the atrial MR or ventricle MR. That will, all these factors will affect LA pressure. So can you predict this procedure will improve LA pressure, and or this parameter will have some impact on your treatment strategy?
Yeah, you're right. I think there are, confounders while we are assess the air pressure, the blood pressure, the heart rate, something else may also, contribute the variation of measure of air pressure. However, we saw that when you, it depends on where the patient have truly, high V-wave pressure. So there are also what we, in the presentation mentioned about the so-called pulsatile, which indicate that the V-wave pressure is what we treat to the patient to make the significant change after mitral TEER procedure. So in our daily practice, we always see the air pressure after first clip implantation. While you abolish majority MR, you may downgrade the air pressure to MR receiver equal less than 2+. When you pursue 1+ or less MR, you probably would not further decrease the air pressure. So just would like to remind that we may pursue the less MR, but may consider if the patient actually, the mitral valve area actually impact on the atrium pressure, which might also have consequent worse outcome. So I don't know, I have no idea how to precise major air pressure. So usually I would prefer to, focus on the V-wave change in V-wave.
So now how about the PV flow?
Yes.
Yeah.
Yes, they are also we know that the abolish the pulmonary vein reverse flow is also related to the long-term beta clinical outcome. So there are numerous factors, including the images, the pulmonary feeding pressure pattern, and also the residual MR. So we don't really see the data on the pressure gradient, so which might be related to mitral valve pressure gradient. I think that might be impact on the mitral valve area. So I have no idea. Maybe the patient with ventricular function might can have more clip without really increase the air pressure. Given the atrium pressure might determine mainly by the LV function. So that would be very different from DMR and also ventricular function MR.
Can I just make a comment about the mean pressure gradient? 4, 5, sometimes if you find that there's no flow reversal in the pulmonary veins, you're worried about mitral stenosis, but how high can you go in that time? Because for us in Malaysia, we take about 4 as the maximum, and not. So I'm not sure. And I think the Asian patients, most of the clips that we use for this will probably be the NTW. And I think there's not much difference in terms of the usage of the clips in the Asian population, although as you've mentioned just now, the body surface area and all that, the heart size is smaller, but I don't think we have any issues using even the XTW for other causes, not SMR, for prolapse and all that. So I don't think there's much difference, but what is your cutoff? 4, 5, or you also combine with the peripheral reversal?
Yeah, I think majorly I would pursue less than 5, so equal or less than 4 millimeter mercury, I think would be best. If you can also have mild equal or less than 1 plus MR. But if you did have higher MR, more MR, 2 plus MR, I think I will pursue, less MR, especially in patient with functional mitral regurgitation. But in patient with a DMR, I would, figure out whether it is related to the pathology, to the prolapse. If it is, I will go for it. I agree that I don't see any difference using the clip size in treating Asian patient. I think it mainly depends on the etiology, which is DMR would always have lengthy leaflet, and for functional, especially Asian functional MR, the leaflet length would determine why we use on the clip size.
One more question. Let's talk about TEER in AFMR. The data from Expand G4 registry AFMR, the mean array volume 80. Mitral tuning registry from European country, mean array volume 70. Our data from our center, mean array volume 200 something. I think that poor outcome is naturally expected. How do you think about your experience? The extreme case may be excluded from in the registry data, I think. Yeah.
Yeah, I believe so. The atrium size is really important, especially it not only affect the procedural outcome, long-term outcome, actually it immediately impact on the imaging, because when patient have very dilated left atrium, you probably are not able to get a good image quality to treat the mitral, and also when patient have large MR, you are also struggling doing the procedure. I think not only for the long term, but immediately during the procedure, you probably would encounter some difficulty.
Yeah.
So just want to comment for atrial functional MR, because after treatment, you don't have optimized GDMT, because for atrial functional MR, because for as long as durability issue is that we're worrying about that for ventricular functional MR, then you can continue with your GDMT and prevent a ventricular remodeling and dilatation. Then we can maintain the degree of mitral regurgitation. For atrial, it's difficult because there's nothing we can do. And what to think about in the direction? Shall we treat, maybe most of the time it's due to atrial fibrillation, and we're treating them very late, because before we don't have ablation that being that common, and the patient already had a huge LA, and then even when we treat them, they don't have a good outcome. So on the other hand, shall we do earlier on, so combined therapy, or after treating the MR, then we continue to focus what we could do for the atrial. So what do you think about this?
Yeah, I totally agree. But if the patient already have 200 million more air atrium, I don't think whether we would apply the catheter or medical treatment are able to really have reason control.
Yeah, so that's why this is a difficulty for treating already hugely dilated atrium.
Yeah.
So you mentioned that we have some indication, for criteria for the atrial functional MR. Yeah, is that correct? Yeah, that's right. Otherwise, we need a new device or other treatment option. Yeah.
May I have last question for Dr. Kang? Yeah, you presented today in your population, actually more than 40% patients have more than 3 or 4 plus tricuspid regurgitation. We know that the impact of tricuspid regurgitation in patient, after mitral TEER. So just would like to, do you have any idea how the patient doing with the tricuspid regurgitation will have a significant regression in tricuspid regurgitation in your patient?
I did not present the data because of the lack of the space. However, the patient with the 3 or 4 plus TEER patient was a little bit decreased after the long-term follow-up. But there was some trend, but not statistically significant because of the small number of the patient. So we could find that the pulmonary hypertension itself was not very well relieved. However, the severity of the TEER was a little bit decreased. However, for atrial functional MR, it was not. Still, there was severe TEER remained.
Oh, thank you. It seems that we did need, tricuspid intervention for patients who have concomitant tricuspid regurgitation. So let's move to the next part of the section. I will invite our first speaker, Dr. Kim, to present what is the best treatment for isolated TEER.
Thank you, Chairman. Good afternoon, ladies and gentlemen. To my great pleasure, I have nothing to disclose. What is the best treatment option for isolated TEER? The definition of isolated TEER is not uniform. Initially included the secondary TEER. The definition is becoming wider and wider, including primary TEER caused by endocarditis and implantable devices like this. This is a guideline from American guideline policy in 2020, how to treat a patient with TEER. Progressive TEER, moderate to moderate severe. At the time of left side valve surgery, the T-valve surgery is indicated as 2A indication. In patients with a severe TEER, the symptoms are very important. Asymptomatic patient, the primary TEER with progressive RV dilation or systolic dysfunction, T-valve surgery 2B indication. A patient with symptoms, the primary TEER, secondary TEER, a prior left side valve surgery, TV surgery is indicated 2 indication. How's the clinical outcome with patient with isolated TEER? This is data from Mayo Clinic, published in 2014. Most of all, regardless of rhythm status, the symptoms, the green line indicates patient with severe MR. The orange line indicates the patient not severe MR. The severity of TEER is very important in this patient group. For a patient with atrial fibrillation with severe TEER, the 10-year survival rate is only 30%. Patient with symptoms and the severe TEER, the 10-year survival rate only 36%, indicating excessive mortality in this patient group. There are many risk prediction models in patients with isolated TEER, but this is one example. But looking at the parameters including Indian nurse, age, MI, and chronic lung disease, and kidney function, and the usual anemia, thrombocytopenia, increased INR, albumin, as indicating, reflecting the liver function, and RV function, and pulmonary hypertension. In patients with a score more than 12, 1 year all-cause mortality is greater than almost 70%, as showing the high risk of these patient group. But this paper published in Heart 2018 review article written by Dr. Nishibura and Mayo Clinic. At the time, how to treat the isolated severe TEER. If a symptom, just increased eye pressure and the rhythm status is very important for determining the treatment option. Patient with a symptom, the second for primary etiology, the primary etiology can be removed with intracardiac device, or secondary etiology, the rhythm control is possible to estimate the surgical risk. After then, high surgical risk, the considered percutaneous intervention. Looking at the data published in United States from the National Inpatient Sample Hospital data from 2004 to 2013 for over 10 years, they found that 5,000 isolated T-valve surgery. Over 10 years, the surgical volume of TVE repair and TVE replacements and the significantly increased. The problem is overall in hospital mortality did not vary over 10 years, around 8.8%. The cardiac shock rate of 6.2. In this paper, the authors found that the mortality predictor of mortality was coagulopathy, hypertension, end-stage renal disease, age, and T-valve replacement in the pro-outcome Chest Comorbidity Index. Looking at the data from European countries, this is data from 12 tertiary hospitals in France. They analyzed almost 500 patients underwent T-valve surgery for functional MR and organic functional TEER, half an per patient. The overall evaluated during 5 years, the all-cause mortality almost 85%. Interestingly, the overall in-hospital mortality was 10% for functional TEER, is poorer than I expected, around 15% in hospital mortality. For organic MR TEER, the outcome is better than organic secondary TEER, around 5%. This is the data from Assam Medical Center for isolated TEER. Interestingly, in our center, the overall early mortality rate just 4.6%. there is no difference of a patient underwent TB repair and TB repairment. Interestingly, the patient underwent TB repair, the risk of a primary endpoint was all-cause mortality plus heart transplantation. The 11% primary endpoint occurred during the follow-up period. As you can see here, the annular diameter at this point, 44 millimeter, the increase of primary endpoint is significantly increased, greater than 1.0. In subgroup analysis, we found that patients with a tricuspid annular diameter greater than 44 millimeter, the tricuspid valve replacement is better than repair. This is a meta-analysis comparing with TB repair and TB replacement. And in 30-day mortality was 4.7 patients underwent the TB repair, and almost 30% for patients under the tricuspid valve replacement. And the 30-minute was better in patients underwent TB repair. Also, the implantation rate lower in patients underwent the TB repair. Looking at the meta-analysis regarding the outcomes of isolated TEER, analyzed 35 studies, including almost 4,000 people. 35 studies are included in the analysis. Overall mortality rate, 12%. And pacemaker implantation rate, 10%. But the interesting data published from Cleveland Clinic 2 years ago, the early surgery, the definition of early surgery not indicate the class 1 indication. In this analysis, interestingly, the operative mortality was class 1 indication, 7%. No mortality rate in patients with early surgery indication. They found that in multivariate analysis, GFR, LV function, and class 1 indication age, diabetes mellitus is the independent predictor of outcome. Looking at the trial evaluating TB tricuspid intervention, many TEER device, MitraClip and Pascal system, bicameral system, Evoke valve system, and TriBand and the Prevent, Scout, Spacer. This is published in the data review article JAHA last year. But the problem is how is the available T-valve device in Asian country? This paper published this year, but the paper submitted July last year. This is as of 2024. T-valve device now available in Japan, in South Korea. TriClip are available in New Zealand, Australia, Thailand, Singapore, Malaysia, Taiwan, Hong Kong, mainland China. However, the other device now available in other Asian countries. This is the final slide summarizing the algorithm for treating isolated TR patient. What is the best option? But most of all, symptoms is very important. But most of all, nowadays, the multidisciplinary heart team evaluation is the most important thing. For palliative patient, the clinical fertility and the medical therapy with the GDMT is both with the diuretics and SGLT2 inhibitor or something like that. In patients with low surgical risk, surgery should be performed. However, low of early surgery is not guaranteed in this patient group. Further studies should be performed to evaluate the role of early surgery in patients with isolated TR. But detailed device-specific imaging analysis should be performed to evaluate which device is suitable in this patient group: TEER, TTVR, transcatheter annuloplasty, and invasive device. Thank you for your attention.
Thank you, Dr. Kim, for sharing the surgical outcome in patients with isolated TR and also point out the unmet need for transcatheter therapy in Asia-Pacific region. So we would like to welcome our next speaker, Professor Horst Silver, who he will share his understanding on tricuspid repair and replacement technology on the horizon.
Okay, thank you very much, and thanks to the organizers for inviting me. As you all know, it started with off-label use of the MitraClip in the tricuspid position many years ago. And today, there are more than 35 devices for tricuspid repair or replacement. Most of them are in development or in early clinical trials and not approved yet. Let's go through the list of devices here. So we have leaflet and chordae intervention. That means direct repair of leaflets or chordae. We have annuloplasty devices, which means reduction of the annulus diameter. Spacers, which mean they fill the space between the leaflets. We have heterotopic valve implantation. That means implantation of valves into the IVC and the SVC. And we have orthotopic implantation. That means direct implantation of valves into the tricuspid position. And we will go through these many devices, kind of a helicopter view, and go one by one. So let's start with the leaflet and chordae interventions. You all know TriClip and Pascal, which are available. Then Dragonfly, which is the new kit on the block coming from China, and the MitraLix, which is currently on hold for some reasons. You know the MitraClip, you know Pascal. Dragonfly, the filler is compressed, which distends on either side of the arms, blocking the orifice, and you can see what this means at the end. MitraClip has a width of 6 millimeters, Pascal of 10, and Dragonfly has 12 millimeters width, so it fills larger space between the leaflets. Mitral device improves leaflet coaptation by grasping the chordae from adjacent leaflets. You can see the concept, so you turn this around and this brings the chordae together, which makes the orifice of the tricuspid valve smaller. Does it work? Yes, we did a couple of cases years ago, and you can see the improvement here in this particular example. When it comes to annuloplasty, you all know this is easy for the surgeons. It's basically their method of repair in most of the patients, but it's more difficult by catheter techniques because you see that many of these devices are not available anymore, so they did not make it at the end. The Cardioband has been developed as an annuloplasty technique for mitral. The same implant and delivery system can be used for tricuspid. It's actually CE marked for mitral and tricuspid, but it's currently not available. Triptar, right atrial appendage puncture, getting access to the pericardial space. A circumferential implant is delivered along the AV groove. Then tension is adjusted. The right atrial appendage puncture hole is closed with an umbrella closure device at the end. Animal trials already started back in 2014, so it takes a lot of time to develop these devices. MIA device, polycore anchors and a thermoplastic elastomere. Multiple anchors are placed into the annulus and they shrink over time and reduce the diameter of the annulus. They found a significant reduction in annulus dimensions in 31 patients, also improvement in TR and in quality of life. Tricuspid bridge implantation, early stage, this has not been used in humans yet to my knowledge. So it's a very simple device. You place 2 anchors at the annulus of the tricuspid valve, and then you select the size of the device, which is finally just kinching the annulus from these 2 sides. Seems to be very effective in animals, what I have seen. The K-clip is based on the surgical K bicuspidization technique. That means suture placed through the commissure, suture along the posterior annulus, tighten the posterior annulus, fold the posterior annulus, and finally you have a bicuspidization of the tricuspid valve. And the clip, the K-clip, is doing the same thing. You put it into the annulus, bring it together, and at the end you have a bicuspid valve instead of a tricuspid valve. Spacers, you may note that the former device from Edwards is not available anymore. The others are ongoing projects. The duo CROI valve, coaptation valve system, consists of an anchor system which is in the SVC, and then this device which is sitting in the orifice of the tricuspid valve. It has a valve inside, so it's a spacer and a valve at the same time. First-in-man trial is ongoing with this device. Coramase also, first-in-man is ongoing. An anchor in the right atrium, a flexible joint between the anchor and the spacer, so the spacer finds its space between the leaflets, as you can see in this drawing here, in this video animation here. TriFlow, tricuspid flow optimizer, 3 anchors in tricuspid commissures. Again, a central mini valve, you see this here. First-in-man has done by Antonio Colombo in Italy. Trilio, we did some bench testing and early animal experiments. Atrial arms for atrial fixation, spacer to block the central and commissural leakages, the ventricular fixation arms to allow clamping of the annulus below the leaflets. This is the concept again. These are the ventricular fixation arms which are pushed through the tricuspid valve, anchored on the ventricular side, and then the atrial arms with the spacer on the atrial side. And finally, the device developed here in Korea, the pivot TR devices. 3 generations or 3 sorts of devices. It's actually a spacer which is put into the tricuspid valve in an oblique position. This can be done as a catheter technique temporarily to stabilize the patient, or as a bridge to other treatment, or also as a permanent implant. And then heterotopic valve implantation. We started with the Sapien in the IVC. This is, I think, not used anymore, but now these other projects are ongoing or already available. The Tric valve is available also in Asia. Here, it's an implantation of a sextupundal valve in the SVC. A second valve is implanted in the IVC. You basically combine the right ventricle with the right atrium, so we have high pressure in the right atrium, but low pressure in the SVC and the IVC, and this improves symptoms of the patient. Innovatric comes with 2 different devices. It's a single device which goes from the IVC to the SVC, which means less risk of migration, better sealing. It's compatible with a wider range of anatomies. One device, a single-step procedure, and if you go for this device here, which has open cells in the right atrium, you still have access to the interatrial septum if that is needed later on for other procedures. Tricento, again, a device which goes from the IVC to the SVC. And then we have the orthotopic valve implantations. We started with the Navigate 5, 6, 7 years ago. This was our first case at that time. This is not available anymore, but all the other projects are ongoing, and all these valves have been implanted in humans. This is the Intrepid from Medtronic. They have the largest experience of all tricuspid valves. The Trisol single dome-shaped leaflet, which hopefully preserves the RV function due to a gradual leaflet closing, suitable for large annuli up to 65 millimeter under development. It's currently transjugular access, but they are working on transfemoral. It can be repositioned and retrieved. The Evoque valve is available. This valve is not retrievable and cannot be repositioned, so this is a disadvantage, but it's approved and in clinical use. Then we have the cardio valve, access transfemoral, minimal ventricular protrusion, a very flat design, only 50 millimeters. And we have the V-Dyne. It's a 28 French access transfemoral. It's a side delivery, which means the delivery system does not enter the right ventricle. It's repositionable and retrievable and goes up to 7 millimeter diameter. And then we have the Laplace device, currently a transjugular delivery system. You see how the systems go down, 26 French only, probably a low risk of AV node due to the design of the valve, AV node complications. Monarch, I haven't heard from them. This slide is 2 years old, but the project is still ongoing. So this field is moving forward very fast on one side because so many different devices are developed, and very slow at the other side because it takes so long to get approval for them. Don't be disappointed. It's always better to have the future ahead of us than behind us. Thank you very much for your time.
Thank you, Professor Silva, for sharing the knowledge, the updated therapy for tricuspid valve. And our next speaker will be Professor Gilbert Tan, who will show us how to optimize procedural workflow in tricuspid TEER and TTVR, the value of fluoro, echo, and also 3D ICE.
Well, thanks very much for the organizers for inviting me to talk about tricuspid. Now that you've seen all the devices, we should know how to do them. And so here, we're just going to focus on 2 different systems. The TriClip system, which is a T-tier system. So there are a number of different knobs. You can see actually one of the knobs is migrated from the CDS to the guide now, so you have different maneuverability to optimize the trajectory. But first, before even do the procedure, optimize the patient. So we bring the patient in usually 24 hours to optimize them, dry them up, especially for T-tiers, you don't have any gaps to worry about. You might even need to start them on inotrope, and you want to maybe do a baseline echo just to make sure you don't get caught by surprise. During the procedure, we typically minimize the tidal volume. We do that for mitral as well, but particularly important for tricuspid that you reduce the respiratory variation. You want to slow down the heart rate as much as possible. You might want to put a shoulder back or A-line on the right shoulder so you can optimize the imaging. And of course, you might have to give diuretics during the procedure to reduce the gap. So let me show you a case, 87-year-old lady, severe TR, high risk for surgery, obviously. And so here, what we do typically, of course, is doing all the baseline view that you might have heard from previous speakers. So this is an inflow explain grasping view. You can see the with and without color. You now do the sweep from the aortic valve side, which is AS, to the PS for the posterior side, just to see what gaps you're dealing with, what kind of mechanism of color. And of course, transgastric view is critical because that's where you'll orient the clip and look at the morphology of the valve. 3D MPR is extremely important. However, you have to have good 2D views to be able to reconstruct to a 3D. And you can see how you can actually really orient the valve properly and also your device properly. Now, in terms of how you start, so unlike the mitral, you straddle on the right atrium and the bicable explained fluoroscopically, and then you basically steer down to the tricuspid valve. We do it in conjunction with echo and fluoro. So here's the example of how my partner is showing it. You can see on fluoroscopy, you just basically go straight ahead, pull back the guide, and advance the clip to straddle. You don't want to be too low in the IVC, otherwise you get yourself in trouble. Now, steering is pretty straightforward. We actually just counterclock the guide and flip it upside down, and then you do a flex. You also go from negative on the guide initially to straddle to go to neutral or even a little plus, and then you go down. So here you go. You see how we flip the guide upside down. We sped up the video a little bit just to show you can see the on fluoroscopy and an RAO projection view, and you can do that on the same time echo, and then you go down onto the valve directly. Now, in terms of steering and trajectory, if you want a more central AS, you retract the stabilizer. If you want to go more commercial, you advance the stabilizer. If you have what we call a septal hugger, you actually can use the L knob now to clock the guide to be more coaxial, and then you just combine these maneuvers with the F knob. It's kind of like the M knob on the MitraClip. You don't want to over F, and then you become a trajectory going more a lateral dive, and you do fluoroscopy to help. So here's the trajectory. You can see this is more anterior septal. You can see how there's RV inflow explain view, and then you can use the transgastric to optimize your grasping orientation. You can also use ICE. As you see here, this is not TEE. You can see this is a Philips ICE system, and you can see you can get a very nice imaging of the leaflets and the device. You can even check the gripper orientation as well. So once you go in there, you again go into the ventricle with the clip closed. This is TEE. You can see how we drop the grippers and see the bangs, and you can see that here on ICE. Same workflow, same system in terms of how you actually visualize it. You can see again what the transgastric view, how you orient the clip. You want to make sure it's perpendicular to the coaptation line so you don't get a side bite, which can lead to SLDA. 3D MPR, as I said, is important in terms of making sure the orientation is properly. You can see you can get more than one view at the same time. You can see the transgastric equivalent view, grasping view, the inflow view. So this is a very useful tool, but it is a lower resolution compared to 2D. And you can see here, you can also get the 3D ICE onto this kind of multiplanar reconstruction as well. Again, it depends on where your ICE is positioned and how you can visualize it. The advantage of that, you can avoid some of the acoustic shadowing of adjacent structure like leads or mitral or aortic devices. Now, fluoroscopy we found to be very helpful. I guess some people do it without, but we'd like to do it with because you can see the orientation and diving very easily like the mitral. So you can see septal dive is up, lateral dive is bottom, and you want to go in exactly the same direction. And when you come up the grasp, you also want to make sure you haven't rotated the orientation. You can check on transgastric view, obviously, but rather than going up and down along the esophagus and risk injury, you can do it on fluoro. So once you grasp, you obviously want to check you have TR reduction. Once you close, you want to make sure you have sufficient leaflet insertion. And more importantly, in the transgastric, you want to make sure you have the double orifice view because 3D is much harder to visualize, unlike in the mitral position. So once you deploy the clip, you obviously want to assess the TR afterwards. Now, what about left groin versus right groin? There were a lot of discussions about that. You can see here, right groin, you obviously get closer to tricuspid valve, which is the default pathway. But some cases, if the IVC is very close to tricuspid valve, you might run out of room. So actually, left groin, you might gain more height and go into the tricuspid valve more easily. But beware of the IVC to the tricuspid annular distance. Just briefly on the replacement system, you can see the workflow actually is very similar. It is fluoroscopic and echo guide at the same time. You can see how you actually fluoroscopically, you can see how you can steer, optimize the trajectory, and then you deploy it under fluoroscopy and also TEE. So with 3D MPRO, which is probably actually absolutely essential here, you can see how you can optimize the trajectory of 3 different views, and also at the same time, with the Evoke system, you need to make sure you do a spin to make sure you confirm leaflet capture with all the 9 anchors here. So you can see that now we have leaflet capture on all of them, and you can release there under echo and fluoro. And so in summary, I think in terms of at least TriClip G4 system, the TEER and the Evoke system, which are both FDA approved right now in the United States, a game changer in the tricuspid transcatheter treatment. You can see a combination of TE, ICE, MPR, and floor really make the procedure not only reproducible now, safe, but also efficient, similar to mitral TEER. And I would say the 3D ICE is really complementary to TE to confirm insertion, especially in challenging situation. But at the same time, if you have trouble with TE, ICE alone can actually facilitate leaflet grasping on TEER or capture in TTVL to avoid SLDA or missed leaflet anchor. And I'd like to congratulate this group from St. Francis Hospital for actually now looking at a streamlined workflow for TEER published in JACC Imaging. And also, I have also done some YouTube videos to talk about these lectures as well. Thank you.
Thank you, dear Bert, for the kind, demonstrate how to optimize the procedural workflow. So, any question from the floor or from the panelists?
So, Professor Kim, yeah. So, in many discussions, we refer to early surgery for isolated tricuspid regurgitation. Early surgery. The importance of the early surgery, we know about that. But in clinical field, we send our isolated TR patient to the cardiovascular surgeon to be late. So, in your opinion, what is early surgery? Is early? What is the definition of early? So, is this the before the RV dysfunction, or is it before the right side heart failure symptoms, such as the pretibial bleeding edema? Or is the imaging criteria? Or is the some hemodynamic criteria? What do you think about that? Is that in our hospital, in our isolated TR patient, we should check every isolated TR patient perform the right side heart cath, and we evaluated the hemodynamic parameter for that patient. So what's your opinion?
That's a very challenging question, but I know the data from your center, the surgical mortality rate of isolated TR is around 1%.
Yeah, 1%.
I think that's the reason why we mentioned about the many patients with early surgery indicated or included in your analysis, I think. But the problem is there is paucity of data regarding role of oral surgery in patient isolated. That's I think that there is no exact definition of early surgery.
Yeah.
The one definition can be the presence of symptom, but in patient with right side heart failure, the problem is the symptom is very vague.
Yeah.
The abdominal distension, peripheral edema, or voice change can be treated. But I think the kind of symptoms are late than usual, lately presented symptoms. But I think every dysfunction parameter, TS, TAPC, or I think the certain volume data from cardiac MR and volumetric CT analysis will be helpful to determine when is the optimal. We don't have any data yet.
Sure.
Yeah.
Yeah.
Can I ask Professor Sivan? I think I only have, at our hospital, we only have the TriClip as well as the tric valve. What do you think of the future? What are the devices that will sort of stay on? There's so many devices. And the problem with the TriClip, you find that imaging, if you don't have eyes, it can be quite challenging, especially if you do the MitraClip and try to get the... So what do you think of the future? What are the things that you would
You
suggest?
seriously asked me to predict the future? I will not do that, of course. I mean, there are so many devices. Many of them are really promising. And I think it will be like with all other devices, like with TAVR, with coronary stents, there will be several devices which will get approval. And it will be partially operator preference, what you use. But in general, I mean, I think for the next couple of years, repair will be the preferred technique, even if imaging is difficult, but it's less invasive at the end. But the problem with everything which is edge-to-edge repair is obviously that you block the future for valve implantation. So that's why I think annuloplasty is actually the best way to go for repair. And we will see the results of the K-clip. So Cardioband is currently stopped, but I think theoretically annuloplasty should be the first way to treat the tricuspid valve, like the surgeons.
I think in terms of valve replacement, the RV function, the current tools that we have to assess RV function, sometimes may not be adequate. Once you replace the valve, there are cases that the RV just fails.
Yeah.
So I think, as you say, it's probably easier to repair rather than put a valve there, because if you cannot really see how to assess the RV function, there will be times that they will just fail after you put the valve there.
Absolutely. A potential solution with that could be the trisol valve, which has a different mechanics of the leaflets, which closes a little bit later. So this seems to be preserving the right ventricular function, but the data are too limited. They have done 15 patients or something like that.
I want to ask Professor Tam. I want to know how often did you use the ice during? No, it's not here. Okay.
3 days.
Yeah, I know you also has ice experience. I want to know how often do you use ice in your TEER procedure? And do you think in the future, maybe the ice will be the default image and then complementary with the TEE? Do you think it's possible?
Thank you. So I think for eyes, it's very valuable in TEER, especially on the tricuspid side. So not only the image could help you at the leaflet level, you can see your grafts, and also you can avoid TEE because always we go up and down, change gastric, then we have patients have GI injury. So but then currently, for leaflet grafting assessment, ice is definitely very useful. But for navigation of the catheter towards the annulus, like kind of stepping back far field, looking at all the trajectories, is still TEE predominantly useful. I think sort of now it's a combined procedure using both modality, but I think in the future they could solve that imaging problem. Then you
so
can just
how many percentage of the case do you usually use ice?
So now for these 2 years, then 100% will be
100%.
But before would be TEE, TTE and 2D ice. But now I think would be good to use 3D eyes. But first of all, we are learning so that even the patient has very good image, we can learn from this process. But I still have patients, maybe they have the mitral replacement before, they have a lot of shadowing, and that sometimes make life very difficult, and you don't want to end up with single leaflet attachments. So, but then we're still in the learning curve, but I think the future is towards that direction.
Simon? I also have a question. I know you also have any experience for the tricuspid replacement. So what do you think when you did not have, do you think in terms, except for the anatomic suitability, which is quite easy understanding, how about the image? If it's only the image restriction, would you prefer the 3D eyes and also the repair, or in which, and also about the RV function? We all know the RV function is very crucial for patients who receive the replacement.
Yes, I think it's a very important question. Other panel can add in, but I think it's still more towards repair is better than replacement. I think even for surgery, I think repair is more tolerate. The patient can tolerate better, especially for RV function. We have a small proportion of patients because the imaging quality is very bad to start with. Then we say, why not go for TVVR because of the less rely on their imaging. But then I don't think this is a good logic, especially we have new modality of like imaging. So maybe more of the physiological based on the patient's pathology. So repair is the number one thing to think of. Yes, but the problem is if we could do some half-hearted repair, leaving behind moderate TL, then it precludes future option for TVVR. So I think trick valve is one of the options. You can preserve all the other options. Well, wait for the future. Then maybe something come up can help the patient is a hybrid way.
So is there any more question?
So just to add another comment about the repair and replacement. I think after we did the TriClip, sometimes we observe a lot of reverse remodeling of the RV, and also I think this is the benefit of the repair system, because after repair we can get the reverse remodeling of the RV. But when we did some replacement because the replacement device is very bulky. Sometimes we put the TTVR and we cannot see much reverse remodeling of the RV because of the device prohibit the reverse remodeling. How do you think about this comment?
So it's time to wrap up this session. I think it's a very valuable session to gather more information for the mitral and tricuspid intervention with a recent advancement. So I would like to thank to my co-moderator, Dr. Song, and all panelists, especially for the lectures, for the wonderful presentation. So thanks for joining this session. Thank you.